What is your timeline for getting this whole program collaborative done, and then going from there? Are you one of you going to put this into practice to really test it out in real time or real life?
Yeah, right now we're, as I said, about 6 to 8 months into that range of collecting data, and really are getting more to trying to see where that data goes as far as bringing it to an outcome, 3-month outcome, and then collecting that, and then looking at that to see what risk potentials have changed that, whether hypertension, diabetes, vascular disease, any of those have changed significantly. Because what you have to do is, if you're going to be talking about an episodic care, actually having a payment for an episode, then you have to have variabilities at the beginning, because different sicknesses are going to add, or different morbidities of people are going to add to their morbidities later on. Mm-hmm. So therefore longer hospital stays, possibly of higher complication rates, and that has to have the flexibility in this. So the model gets pretty complex once you start adding the beginning of what are the possibilities that are factors that are going to change outcome for patients, meaning other medical issues, other things. So the actual surgery itself may not be the thing that changes some of this. It may be other avenues. Or if the person has a more complex surgery, or it's the second time around, that's going to change different things. But right now we're trying to stay with a very simple model. But even with that simple model, the beginning of it, saying what the actual medical problems are of the patient going into the surgery may add to complication rates being higher. And therefore you have to change what the cost of that episode would be. So it's a complex thing. So we're in the beginning stages of it. Middle stages would be where we're just trying to start to, where we're going to try to collect that data and then see how it's applying, and then we'll be able to actually get to the bundling. So I can't tell you how long that timeline is going to be, but it's progressing exactly on course as they had thought it would up till now. So.
Okay, so it's open-ended until you reach.
Till we reach that what we would call what we call our stage 3, which is meaning we're getting to an episodic care or bundle of a bundle payment of saying this is what it's going to cost. This is what we're allowing for this person. That takes some time to put that all together.
Okay, so based on where you're at this point and what you know so far, do you think that this model might be transferable to other therapeutic areas of care?
I mean, I have to admit, I went into it with some reservations about even looking at this, because as physicians, we're always feeling that as time goes on, things are getting taken away more from our payments, our things, and trying to keep a practice going and trying to do all those things has been concerning. Insurance companies working with us and saying they want to work with us, you get a little bit skeptical, because they've kind of been somewhat, you would say, maybe the enemy, because they're the ones you're fighting with to say, hey, we deserve this. We've been working with these patients and doing these things. What happens is it's actually been a very friendly type thing, and you're actually looking where the model actually looks like you can see how this could work, and that this could actually be beneficial to everybody, to physicians, because they have some control of how they're caring for their patients, getting to select what they think is right for their patients without having anybody say, no, you don't need this test, because we've already set some standards, and then seeing a better outcome, better health care, better outcomes for our patients would be fantastic, and that's really look like what it's trying to do. So I think if you can make this work for this, I can't say it could apply to every single medical type thing, but for most orthopedic procedures, those kind of things, it'd be very easy if this model works to then apply it to other models.
How do you foresee the quality of care being better for the patients from their experience?
Well, I think that the idea is that as much as when you watch sometimes a routine, meaning that we have standard type things and goes and it almost looks like a machine, it's assembly line and it's this, and this. The thing that I've even seen in hospitals with discharge planners coming in and making sure people are ready to go at certain days and what you're checking else, that kind of putting it through the system, the body's different. It doesn't work the same way for everybody. Some people are going to have more pain afterwards. Some people are going to have less pain. Some people are going to move their knee right away. Some people are going to have more trouble with their knee. Some of that can be surgery related, but some of that is just difference in people. But having some standardization of how you go about doing that, seeing where it comes, are giving people the best chance to get plugged into that system and to come out at the ending with the best chance of an outcome, with the least amount of chance of complication rates and least amount of chance of therefore readmissions, or having an overall great outcome. I think they get the best chance of having a great outcome with that, and that's what they're going to see. If a patient at the end of this thing you can talk to them about, well, we did this and we did that and everything else. They can move their knee and they can function and they don't have discomfort, or they can use their hip, they can walk around and do stuff. That's all they care about. That's their outcome. How it goes through, you want that to be a great experience for them. And the idea is when you're doing the best things all the way around, then you are giving the best they can. Again, people can vary on how they feel about that as far as what it is, but what I can see is, or foresee and have already seen it already happening in medicine, that it's giving better outcomes, even though you're saving cost.
Do you have any other thoughts that you think would be relevant to what you're doing now?
No, I would just, like I said, I kind of went into it being skeptical about working with an insurance company and everything else. It's been amazing that this looks like a way of actually looking at it in an episodic care way that could actually save money for everyone, yet increase quality for patients. I mean, that's a win-win situation. And so I was not expecting that as a possibility, and being around the people and talking, even though I think we've got a lot of work still ahead of us, that's where it looks like it's headed. So I think it's been a great surprise to me, and I've been very happy that I'm giving up some time to go over and go to these meetings, because it actually looks like it's going to come out to something else. You go to a lot of meetings in your lifetime and do a lot of things where you're sitting around, you're looking around everywhere else. This is kind of exciting because it looks like it could actually become something that would be a model that can be used for the future.